Hello, I'm Dr. Damien Lafferty, a surgical podiatrist. Today I want to address a question I'm often asked after nail surgery. Why did a separate piece of nail grow back after my procedure? Modern ingrown toenail surgery has a very high success rate. However, in a small number of cases, a nail spicule or secondary nail fragment can form and continue to grow. Much of my nail surgery work involves correcting previous procedures, so over time I've developed clear views on why this happens and how it can be prevented. Understanding the cause is the key to managing it properly. The goal of ingrown toenail surgery, whether it's partial nail avulsion with phenolization or a sharp wedge resection, is to permanently destroy the germinal matrix. The germinal matrix is the tissue that produces the nail. If even a small portion of this matrix is left behind or protected from phenol or surgical excision, it can continue to produce keratin. At a microscopic level, the nail matrix is made up of keratinocytes supported by a basement membrane. Phenol works by coagulative necrosis, destroying those cells so they can no longer replicate. If phenol contact is uneven, too brief, or diluted by bleeding, then matrix destruction is incomplete. During healing, the body re-epithelializes the area. Any surviving matrix cells can migrate and re-establish growth, leading to a delayed recurrence. This often explains why a nail shard appears months after an apparently successful procedure. Several practical factors increase the risk of this complication. Incomplete exposure of the matrix, phenol contact times under 60-90 seconds, bleeding that dilutes phenol, inaccurate wedge dissection, leaving behind the lateral matrix horn, thickened or fibrotic proximal nail folds that obscure visualization. Even with good technique, the literature reports recurrence rates of 1 to 5%. Almost all are due to incomplete matrix destruction, not regrowth of the original nail. Certain patient factors can also increase risk: younger age and rapid nail growth, infection or excessive postoperative drainage, early soaking or trauma after surgery, poor vascularity or uncontrolled diabetes. In some cases, the extra nail is not actually nail at all, but hyperkeratosis or scar tissue. This distinction is made clinically, often using magnification. When a patient presents with pain or a visible nail shard, the aim is definitive correction. Assessment includes careful inspection under good lighting, palpation for a hard keratinized ridge, ultrasound in chronic or complex cases to identify residual matrix tissue. Treatment options include simple spicule removal if superficial rephenolization under local anesthetic, revisional wedge excision to remove the remaining matrix horn. When the matrix is fully addressed, revision success rates exceed 95%. In summary, a separate nail piece after surgery almost always results from survival of residual matrix cells. Prevention depends on meticulous technique, adequate hemostasis, sufficient phenol contact time, and full visualization of the lateral matrix. For patients, it's important to know this complication is uncommon, usually minor, and very treatable when managed correctly. With proper revision, outcomes are typically permanent and pain-free. Again, this reflects my personal opinion, developed over 12 years of education and nearly 30 years of clinical experience. If you have questions, please feel free to ask.